continue to be the significant health challenge in pediatric practice in our
यहीं
country.
लगा लेना, ठीक है, थोड़ा आधा घंटे में चलेंगे, यहीं लगा लो.
It often presents with wide spectrum of clinical manifestation ranging from asymptomatic infection to acute liver failure, making it challenging in pediatric practice. Now, without wasting time, I welcome Dr. Amit Modi, who is a program coordinator for today's session, to continue the further session.
Thank you, Dr. Lalit. Good afternoon, everyone. On behalf of IPS Delhi, I welcome you all for joining this session on viral hepatitis. We have with us our own pediatric gastroenterologist from East Delhi, Dr. Ashok Goel, to enlighten us on this topic. Today's CME on viral hepatitis will help us refresh our knowledge on this topic. We also have with us Dr. Forum, PG resident from NIMS Noida, who will present the STG guidelines on viral hepatitis. And it will be followed by a discussion and interaction over the topic by Dr. Ashok Goel. Now I request Dr. Ajay Gupta sir, President IP Delhi, to say a few words of motivation.
Thank you, Dr. Amit. Good afternoon, everyone. I welcome you to this session on STG on viral hepatitis. With the onset of summers, we know the viral hepatitis, especially hepatitis A, is on the rise. So we must be aware what to do in such cases. And nowadays, hepatitis A vaccine is not available in the government setup. So the likelihood of getting hepatitis A patients who receive vaccinations in the government setup is very high. So we must not miss the opportunity to vaccinate such children whenever they visit us and offer them hepatitis A vaccine whenever possible. So without wasting much time, I request Dr. Amit Modi, please continue.
And Ajay sir, please convey your message for PCNI also.
Yes. So I request everyone to please register for the Pediatric Conference of North India, the flagship program of IIP Delhi. It will be on 20th and 21st of June at Hotel Lee Meridian. Special offer is available for all IIP Delhi members. So I request all of you to please contact either Dr. Lalit Gulati or Dr. Puneet Sharma for the special rates. Thank you.
Thank you, sir. Now I request Dr. Puneet Sharma, sir, President IIP East Delhi, to say a few words.
Thank you, Dr. Amit. You are being the coordinator for this month's program, and in part of our continuing medical education for postgraduate students, as we have planned that every month 2 or 3 sessions will be done by the postgraduate students. Today is one of such sessions on viral hepatitis. So, as you know, the viral hepatitis varies from asymptomatic to symptomatic disease, and varying from just nascent infection to the hepatic failure. So, though vaccine is available, but it's not available in the government setup. So the awareness, and it's our prime duty whenever children are coming for the primary vaccination and the just OPD follow-up. So we have to tell the patients about the availability of the hepatitis A vaccine. Not only hepatitis A vaccine, we know that various other hepatitis viruses are also prevalent, including some uncommon causes also. So especially we will be touching upon the protocol regarding hepatitis A, B, C, whatever is there, not uncommon causes. So I think this will be very informative session for all of us. So thank you very much, and over to Dr. Amit. Please carry on.
Thank you, sir. Now, without further ado, I request Dr. Forum to start the presentation. Dr. Forum.
Dr. Amit, Dr. Dinesh Goyal is here, Secretary IP Delhi.
Yes, sir. Now I request Dr. Dinesh Goyal, Secretary IP Delhi, to say a few words.
Dr. Dinesh, please.
Dinesh, sir. Dr. Dinesh.
वो अटेंडी लिस्ट में है।
वेरी गुड
Okay.
आफ्टरनून। हाँ, कोई बात नहीं, वी आर इन ऑफिस।
Okay.
At the outset, I would like to congratulate the IIP Delhi and Amit Modi and Dr. Puneet Sharma and Lalit Gulati for a continuous academic session on every Wednesday. And it's a great start for the newcomers as well as the practicing pediatricians. So my all best wishes from IIP Delhi, and you all are welcome in PCNI 2026 on 21st June. Thank you. Please continue.
Thank you, sir, for your motivational word. Now I request the forum to start the session with your presentation.
Hello. Good afternoon, everyone. Am I audible? Hello.
Yes, you are audible. Start.
Okay. Good afternoon, everyone. Myself is Dr. Foram Ghudasra, pediatric second year resident from the NIMS, Greater Noida. And today we are discussing about the STG protocol on the viral hepatitis. Let's have a look on the definition. The acute hepatitis. Acute hepatitis. It is a clinical syndrome characterized by the acute onset of the liver dysfunction, usually over the period of the 4 weeks, characterized by elevation of the transaminase with the variable synthetic dysfunction. And the chronic hepatitis, it is a chronic elevation of the transaminase. A specific time limit is not defined. Now, let's look on the acute hepatitis. When the child come to us in OPD or the IPD with the presenting features like the jaundice, nausea, and vomiting, or the pain over the right upper quadrant of the abdomen, we have to suspect the acute hepatitis. Now, incubation period of the hepatitis A and E is 2 to 4 weeks. It starts with the prodromes like the anorexia, nausea, vomiting, low-grade fever, and the pain over the right hypochondrium and the malaise, followed by jaundice. The risk of the acute liver failure in hepatitis A and E is less than 0.1%, but there is some risk. So we have to look for the danger sign when patient came to us. Danger signs like the abnormal behavior, irritability, sleepiness, altered sleep rhythm, abdominal distension, persistent fever or the vomiting, rapid decrease in AST and ALT, and the INR more than 1.5. Then we initiate the liver failure management. Now, let's look on the causes of the acute hepatitis. The most common cause of the acute hepatitis in India is acute viral hepatitis A. Other hepatitis are hepatitis E and the hepatitis B, which are less common. Other non-hepatotropic viruses like dengue, parvo, CMV, Epstein-Barr, herpes, etc. And other are the dengue, drug-induced hepatitis and the autoimmune hepatitis. Some are the bystander hepatitis like malaria, enteric fever, leptospirosis, and the scrub typhus. The acute onset of the chronic liver disease, which we also have to figure it out. Like the acute hepatitis may be the first presentation of the underlying chronic liver disease. Now, let's discuss the differential diagnosis of the acute hepatitis. When the child came to us with the fever and the acute illnesses with the elevation of the liver enzymes like ALT and AST, then first we suspect the acute viral hepatitis. In the acute viral hepatitis, fever resolves after the onset of the jaundice and the ALT and AST increase by 10 to 20 times of the upper normal limit. In this, the INR may be deranged, which shows the liver failure. Now, second is the malarial hepatopathy, in which jaundice within the first week of fever and associated with the anemia and the splenomegaly. And the liver enzymes like AST and ALT increase by 3 to 4 times of upper normal limit, and there is normal INR. And in enteric hepatitis, there is continuous fever. And enteric hepatitis and liver enzymes here also increase by 3 to 4 times, and the INR is normal. Another differential diagnosis may be the leptospirosis, in which there is biphasic illness, jaundice beyond 2 weeks, and there is renal involvement with or without bleeding. And we all know in the dengue hemorrhagic fever that there is SIRS, shock, hemorrhagic manifestation, and the capillary leak. In the rickettsial infection, there is persistent fever associated with the lymphadenopathy or the hepatosplenomegaly, ulcer, or the scar in the groin or the axilla, and there is ARDS. Now, if the child came with us with the fever and acute illness, but there is disproportionate ALP and the GTT, then we look for the biliary cause. And biliary cause may be the choledochal cyst, cholelithiasis with the cholecystitis, biliary ascaris, sickle cell hepatopathy, or the primary sclerosing cholangitis, in which we have to look for the gallbladder or the CBD stone on USG and the MRCP. Now, let's move on where the fever is not there. Absence of the fever or the incidental detection of the elevation of liver enzymes like AST and ALT. First, we suspect the resolving acute hepatitis, in which there is fever subsides and only the liver enzymes are elevated. Second is the drug-induced liver injury, in which there is rash, eosinophilia, that is DRESS syndrome, with or without liver failure. Another is autoimmune hepatitis, in which there is elevated IgG, autoantibodies, and there is liver biopsy is diagnostic. Another is the non-hepatic causes, in which we check for the CPK for the muscle involvement, smear, DCT, LDH for the hemolysis, and the glycogen storage disorder type 3, 6, and 9, where liver is affected, in which there is hepatomegaly, hypoglycemia, lactic acidosis, elevated triglyceride, and there is no jaundice. Another, where the absence of the fever, but incidental detection of the ALP raised with or without GGT raised. First, we think of the vitamin D deficiency. Another is choledocholithiasis in biliary colic, cholecystitis, liver disease, in which there is pruritus, jaundice, xanthosma, fat-soluble vitamin deficiency are the features of the cholecystic liver disease. Another is the infiltrative liver disease. There is findings like the seborrhea, skin lesion, air discharge, and the lung involvement, that is LCH, Langerhans cell histolytica. Now, there is an algorithm to diagnosis for the acute viral hepatitis. When we suspect the acute viral hepatitis, is first we look for the prodromal symptoms, like as we discussed earlier, like prodrome symptoms like anorexia, nausea, vomiting, low-grade fever, pain abdomen, followed by jaundice, acute elevation of the liver enzymes, and the rise in the bilirubin over the 4-week of period. Then first we go for the step 1, in which we look for the viral markers, because the in the acute viral hepatitis A, B, and E are the more the common one. So we look for the IgM hepatitis A, IgM hepatitis B, HBsAg, IgM NT, HBC, LFT, INR, etc. If one of this is positive, we suspect the hepatitis A, B, and E positive. Then we'll watch for the danger signs. If any danger signs present, we suspect the liver failure or treat accordingly. Now, if there's negative viral marker, then negative for the hepatitis B, A, B, and E. Then look for the persistent fever. If persistent fever is present, then we look for the alternate diagnosis like the malaria, dengue, typhoid, leptospira, scrub typhus, etc. And another viruses like cytomegalovirus, Epstein-Barr virus, parvovirus, HHV, and the HSV. And also, we have to look for the HLH, that is hemophagocytic lymphohistocytica, in which there is cytopenia, splenomegaly, and the rash. Investigation finding are the elevation of the ferritin more than 500 microgram per liter and the low fibrinogen, that is less than 150 milligram per deciliter. If there is no persistent fever, then look for the autoimmune hepatitis, Wilson disease, non-liver causes, and the drug-induced hepatitis. The key feature of this we discussed earlier. Now, the pediatric acute liver failure. It is the biochemical evidence of the acute liver injury with no non-evidence of the chronic liver disease with hepatic-based coagulopathy. So it is defined as when the PT more than 15 seconds or the INR 1.5 more than 1.5 and which is not corrected by vitamin K in the presence of clinical hepatic encephalopathy, or when the PT is more than 20 and INR is more than 2, then regardless of the presence or the absence of the hepatic encephalopathy, we have to manage as the acute liver failure. Now, let's move on to the chronic hepatitis. The chronic hepatitis, as we all know, there is chronically elevation of the liver enzymes, but on the per abdomen finding, we find the firm liver, splenomegaly, ascites, and the dilated abdominal vein. And the stigmata of the chronic liver disease are the growth failure, palmar erythema, spider nevi, facial telangiectasia, clubbing, and the pedal edema. Also, the features of the fat-soluble vitamin deficiency, like the xanthelasma, scratch marks, and the hyperpigmentation. And on the ultrasound, there may be a coarse nodular liver with the dilated portal veins and the collaterals. And on endoscopy, there is paresis. Now, let's discuss the DD of the chronic hepatitis. First, we think of the autoimmune hepatitis, in which there is recurrent or the first episode of the recurrent hepatitis. Another autoimmune conditions also associated, like the Coombs positive hemolysis, celiac disease, thyroiditis, rheumatoid arthritis, SLE, etc. There is high IgG, and there is also the autoimmune autoantibodies are present, like ANA, SMA, LKM, SLA, LC, or the p-ANCA. Now, another is the Wilson disease. In the Wilson disease, rapidly progressive jaundice, which was progresses to the ascites and the and encephalopathy. And there is Coombs negative hemolysis or the hemoglobinuria. There is investigatory finding like the low ceruloplasmin or the high 24-hour urine copper that is more than 40 microgram per day. And there is on examination, care fishing also may present, or the extrapyramidal or the psychiatric symptoms may seen. Now, another is the reactivation of the chronic hepatitis B virus. In the reactivation, there is underlying hepatitis B, deepening of jaundice, encephalopathy, ascites, and the coagulopathy. Another differential diagnosis may be the primary sclerosing cholangitis, in which we see the Charcot triad. Charcot triad is a triad of the three main symptoms like pain abdomen, jaundice, and the fever, associated with the disproportionate ALP GGT elevation. And on the USG or MRCP, look for the intrahepatic biliary radical dilatation. Another maybe the diagnosis is the metabolic liver disease, in which there is hepatomegaly, failure to thrive, family history of the consanguinity, extrahepatic features also may present, bone marrow, GI, muscle, cardiac, pancreatic, or the CNS. There may be the episodic illness precipitated by fasting, stress, or the specific food. Metabolic liver disease includes the fatty acid oxidation defect, mitochondrial hepatopathies, gluconeogenetic defect, or the urea cycle defect. Now, let's move on to the hepatitis B. It is very important because 2 million people, that 2 billion people, that is 1/3 of the world population exposed to the hepatitis B virus, out of which 400 million people chronically infected, that is 6% of the whole population, and out of which 2/4 lives in the Asia Pacific. It is also important because hepatitis B virus causes 57% of the global cirrhosis and the 78% of the hepatocellular carcinoma. Most common mode of transmission of the hepatitis B is mother to child transmission, that is 50 to 70%. And the chronicity risk by the age of infection, as we all see, that in the perinatal, more than 90% risk, in the infant and under 5 children is 25 to 30% risk, and in the adolescents to adult is less than 5% risk. So, younger the age of infection, higher the risk of the chronicity. Therefore, we give the perinatal hepatitis B vaccination is very important. Now, let's look on the phases and the treatment indication of the chronic hepatitis B. First, we do the HBsAg, look for the if hepatitis B is present or not. Then move on to HBeAg. If HBeAg is positive, there are two categories, immunotolerant and immunoactive. On if normal ALT liver enzymes, but the HBV DNA is more than 20,000 international unit and HBeAg is positive, it is called immunotolerant. But when the liver enzymes is normal, we don't have to give any treatment, but just to follow up for the 6 months. Now, another category in which there is elevated liver enzymes, HBV DNA is more than 2000 international unit per ml, and HBeAg is also positive. We initiate the treatment immediately. Now, another category in which HBeAg is negative, but there is elevated liver enzyme and HBV DNA is more than 20,000 international unit, then we initiate the treatment, and it is called the HBeAg negative chronic hepatitis. So, in the chronic hepatitis, we do the liver biopsy before starting the treatment. And another category in which there is elevated liver enzymes, but the HBV DNA is less than 20,000 international unit and HBeAg is also negative. So it is called the inactive carrier. And in this, we don't have to give any treatment and the follow-up for next 6 to 12 months. Choose our patient carefully before starting the antiviral to avoid the development of the drug resistance. Now, as we see in this graph, we discussed earlier, but we see in the graph and understand the graph properly. First, HBeAg is positive. First category, immunotolerant, in which the HBeAg is positive. And HBV DNA is also more than 20,000 international unit. But the ALT is not increasing. So it is called immunotolerant and there is no treatment required. Another category is immunoclearance or the immunoactive category, in which there is HBeAg is positive. HBV DNA is also rising and the ALT is also rising. So in which we have to give the treatment and initiate the treatment immediately. Another category in which HBeAg is negative. So there is anti-HBe is positive, in which there is ALT, the liver enzymes, and the HBV DNA is undetectable. So it is called the inactive carrier state. And in this category, we don't have to give the treatment. Another category is in which HBeAg is negative, but there is HBV DNA and liver enzymes are rising in between. So it is called reactivation or the HBeAg negative chronic hepatitis. We have to give the treatment in this category. Now, let's moving on. There is some special scenarios in which we have to treat immediately, regardless of the above criteria we have discussed. It is mentioned as the HBsAg positive with the decompensated cirrhosis, reactivation of the hepatitis B, family history of the hepatocellular carcinoma, or the acute hepatitis B with liver failure like INR more than 1.5 or encephalopathy. Or if we are planning for the immunosuppression or organ transplant, then we have to treat immediately. So it is called the special scenarios. Now, there are some treatment guidelines according to some associations. Like the American Association says that they are treating the children with the age group of the 2 to 17-year-old with the elevated ALT and the measurable HBV DNA. But the Asian Pacific Association, they are treating the children with the ALT more rising by the 2 times of the upper normal limit and the moderate inflammation or the advanced fibrosis on the biopsy. Also, HBeAg is negative with the elevated ALT or the significant fibrosis or the cirrhosis or the reactivation, or there is positive family history for the hepatocellular carcinoma. Another is the European Association. They are treating the children where the ALT elevated more than 6 months or the HBV DNA is more than 2000 international unit per ml. Also, there is inflammation or the fibrosis on the biopsy. There is positive family history of the hepatocellular carcinoma, or there is reactivation in the immunocompromised state. Now, when we are giving the treatment, we have to have some aim. So overall aim is to improve the long-term survival and the quality of the life by reducing the risk of progressive liver disease, cirrhosis, or the hepatocellular carcinoma. And the ideal endpoint should be the sustained HBsAg clearance, stop disease progression with reduced HCC risk, which is rarely achievable. That is in the around less than 5% cases. But the achievable goal, or that should be our main goal, is to zero conversation of HBeAg, that is HBeAg negative and anti-HBe antibody is positive. Or with other goal is like normalization of the ALT with separation of the HBV DNA to undetectable level. And the monitoring tool is the transient elastography or the fibroscan, routinely done in the adult, but the feasible non-invasive option in children too. Now, some are the drug options in the drug regime for the hepatitis B. There are interferon and some are the nucleotides and the nucleosides. The mechanism of action of the interferon is, as we know, the interferon are the immunomodulator. They can decreases the CCC DNA load and causes the HBsAg loss. And the nucleosides are inhibit the viral replication. So interferon alpha we give more children of the age more than 12 months, and the duration of the interferon alpha is 6 months. And the peg in interferon alpha 2ab we give in the children of age 2 to 18 years, and the duration of the treatment is 6 to 10 months. Now the nucleosides or the nucleotide lamivudine and encavir entecavir, it is used in the age group of more than equal to 3 years, and the duration of the treatment is more than 1 year. And the tenofovir and edifovir we give in the children more than year of 12 years, and the duration of the treatment is more than 1 year. The interferon are we give the parenterally or the subcutaneous injection, and there is no resistance of this treatment, and this not used in the decompensated cirrhosis. And the lamivudine and in lamivudine there is risk of the mutation, and entecavir there is negligible resistance and preferred oral agent. And tenofovir there is high response, no resistance, and monitor bone mineral density along with this. So there is some combination sequentials are present, like the nucleotide or the nucleosides are given for 48 weeks and add the interferon at the week of 8, so that the nucleosides and the nucleotides, they decreases the viral load, and then interferon will give once the viral load is less, and it is boost the immunity against the virus. Now, as we all know, there is the chronicity risk in the newborn or the perinatal period is more than 90%. So we give the prophylaxis to the newborn born to the HBsAg positive mother is very important. Hepatitis B immunoglobulin and HBV first dose vaccine giving, we have to give within the 12 hours of life, and another vaccination dose, 3 more doses given at the 2, 4 and 6 month or the 6, 10 and 14 week. Now, test for the HBsAg and anti-HBs titer at the 3 to 12 months after the last vaccination dose, and do not test before the 9 month of age. Screening for the family member is very important in the hepatitis, or it is the prevention therapy. Test for all the household contact for HBsAg for the active infection, and another are the anti-HBC antibody and anti-HBs antibody. Anti-HBC antibody for the resolved infection, and the anti-HBs antibody for the protective immunity. So if the anti-HBs antibody are less than 10 international unit per ml, then we have to give the 3 doses of vaccination at the 0, 1 and 6 month. In the resource limited setting, we can do is the HBsAg testing and the vaccination. Now, let's move on to the hepatitis C. Hepatitis C virus is a single-stranded RNA virus of the Flaviviridae family. Hepatitis C virus is now curable with a modern DAA, directly acting antiviral therapy. Prevalence is 3.5 to 5 million children worldwide, and the mother-to-child transmission is around 5% overall, and the higher with the HIV co-infection and HCV RNA more than 6 log international unit per ml. 25 to 50% of the mother-to-child infection resolves spontaneously by 3 to 4 years of age. Now, the mode of transmission of the hepatitis C are most common transmission mode in the children are the mother-to-child transmission. Other are the intravenous drug use, tattooing, unsafe injection practice, blood transfusion, high-risk sexual activity, intranasal cocaine use. But the route of the delivery does not influence the vertical transmission, and the breastfeeding is not contraindicated unless there is HIV co-infection. Now, the screening for hepatitis C is very important. There are we can screen for anti-HCV antibody and also HCV RNA assay. The child born with the HCV positive mother screen for the anti-HCV antibody at or after the 18 month of age, and HCV RNA can be done after in first year of life or even at the 2 month of age. If the HCV positive anti-HCV is positive after the 18 month, confirm with the HCV RNA assay after the 3 year of age. Siblings born of the same HCV positive mother should also be tested. And the further evaluation with the LFT, PTINR, CBC, alpha fetoprotein, and the USG molybdenum. Clinical course of the hepatitis C is slow and indolent, usually minimum or the no symptoms. Advanced liver disease infrequent until more than 30 years of infection. The high-risk group needing the careful monitoring are the non-alcoholic fatty liver disease, congenital heart disease with increased right heart pressure, thalassemia, those receiving the hepatotoxic medication. In the follow-up with the LFT, PTINR, CBC, alpha fetoprotein, and USG whole abdomen every 6 months to annually. Screen for the co-infection, that is hepatitis B and the HIV. Liver biopsy is not routinely needed before the treatment, but may be needed if there is suspicion of the advanced liver disease or the comorbid condition may influencing the treatment pathway. Now, some treatment regime for the hepatitis C. The treatment naive or the interferon experienced in the children and the adolescents without cirrhosis or with the compensated cirrhosis are like the SIVO. Some regimens are, these are the regimen used in more than 3 years of child, and the regimen are like sofosbuvir or velpatasvir, genotype, pen genotype, and the duration of this treatment is 12 weeks. And the sofosbuvir or ledipasvir, the genotype are 1, 4, 5, and 6. Duration of the treatment is 12 weeks. And the glecaprevir or the pibrentasvir, pen genotype, and the duration of the treatment is 8 weeks. Now, the new treatment is the directly acting antiviral agent. It is the mainstay treatment because it is simpler, higher effective, and FDA approved. It is also cost effective. It delaying the treatment until the early adulthood and may increase the lifetime risk of the advanced liver disease. DAA agent are the NS3-4A protease inhibitor, NS5A inhibitor, or the NS5B polymerase inhibitor. The recommendation for all the children or the adolescent more than equal to 3 years of age, regardless of the disease severity. Now, we see some DAA regimes like ledipasvir or the sofosbuvir, prior interferon with or without ribavirin, or with the hepatitis C virus protease inhibitor. Genotype is 1 and used in the age more than 3 years of age. And the duration, if there is no cirrhosis, then duration of the treatment is 12 weeks. And if there is compensated cirrhosis, the duration of the treatment is 24 weeks. And the if the similar regimen is used, but the genotype are the 2, 4, 5, and 6, then the duration of the treatment, regardless of the cirrhosis, is the 12 week. Another is glecaprevir 300 and the prebentasvir 120 with the prior NS5 inhibitor. There is genotype is 1 and used in the age more than 12 years, and the weight is more than 45 kg, and the duration of the treatment is 16 weeks. Thank you so much, sir. And thank you so much, everyone, for listening me.
Thank you, Dr. Forum, for such a wonderful and lucid presentation.
Thank you, sir.
Now I ask Dr. Ashok Goel to give his views and enlightenments on this topic.
Thank you, sir.
Dr. Ashok.
Thank you, Dr. Forum, for this wonderful presentation. I think the topic is very clear to everyone, the standard treatment guidelines for viral hepatitis. I think she has already done a very wonderful job by elaborating this very vast topic. But two things that I would like to tell that, yes, as sir already told us that this hepatitis, or especially that viral hepatitis, is a very fulminant condition with intermittent breakthroughs. As doctor has already discussed that the chances of liver failure is less than 0.01%, but still it is there, and almost 50% mortality is there once patient lands up into this acute liver failure. So vaccination is the gold standard. We have vaccines available for hepatitis A and hepatitis B. Schedules is there, and every child should get this vaccination as soon as possible within birth. And another thing is that the perinatal mother to child transmission of this hepatitis B, Dr. Forez already discussed that the perinatal transmission has got a chronicity of more than 95%. But in that case, if the mother's HBE antigen, which is basically a replicative marker, it is more than 2 lakh, then the chances is very high of having the chronicity as well as the active disease in child. So other than that, there are some atypical manifestation of viral hepatitis that we have not discussed in this particular presentation, because the topic was to treat the acute viral hepatitis as well as the chronic hepatitis. So if the patient presents with atypical manifestation, commonly it is associated with hepatitis A virus, that is cholestatic phase of hepatitis, as well as the relapsing hepatitis. So these are other two conditions, but apart from that, we have this non-hepatotropic viruses that can cause variable presentation with viral hepatitis. So that's all from my side, and congratulations to Dr. Fora and IAPs Delhi for organizing such an good academic activity.
Dr. Ashok, there are some questions in the chat box, if you take them.
So there is a question by Dr. Lalit, that what are the early warning signs should alert a pediatrician to impending acute liver failure? Are there specific lab parameters that reliably predict severe disease? And when should we refer a child to a higher center? So yes, sir, it is very important to look for the dangerous sign, as Dr. Fora has already discussed in her presentation, that are rising INR, values of PT prothrombin time, when the patient in situ into this encephalopathy, whether it is grade 1, grade 2, or grade 3 encephalopathy, deepening of jaundice, bleeding manifestation, and collection of this developing ascites. So all these are features which can tell you that the patient is in liver failure. But the most common that we look are the rising trend of INR and PT values, as well as this encephalopathy. So these are some dangerous signs which we should look into every child that present to us with viral hepatitis. And if it is there and they are not correctable through vitamin K and other supportive measures, we should ideally refer this child or patient to the higher center where the facility of liver transplant is there. Please, another question by Dr. Tangwal sir, that please suggest an algorithm for investigation in OPD practice, child presenting with hepatitis A virus. So it depends. There are two school of thought, sir. When the child, there are some poor prognostic parameters in which if the child is less than 1 year and more than 10 years. So in both these circumstances, the prognosis is very bad. There are some parameters through which we can label whether the prediction of mortality is high or not, or the disease severity is high or not. So if the patient is more than 10 years, we usually do a basic hemogram along with this LFT and PTNR. And if the OTPT is very high, sky high, more than 500, we usually think of this viral hepatitis, because in viral hepatitis that OTPT can go up to thousands also. I have seen in my patient that 22,000 and 40,000 reports also. So these are the basic parameters that we can do. But apart from that, if you think that the patient is having a prodrome of having a suspicious of viral hepatitis, then yes, then we can test for hepatitis A and hepatitis E also. But nowadays, lot of patients are coming and they are having this value of hepatitis A IgM and hepatitis E IgM negative, but still we strongly suspect that the patient is having viral hepatitis. So there are some reports, or there are some article in which they have mentioned that if you do these testing very early in initial phase, whenever we do this testing in phase 1 of acute viral hepatitis, then there are chances of having negative reports. So it is ideally should be done after 48 hours of a peak ALT value, which usually comes in phase 2 of acute viral hepatitis. When I say phase 1, phase 2, and phase 3 of acute viral hepatitis, I mean to say in phase 1, there will be sharp elevation of the transaminases, that is SGOT and SGPT. And at the end of phase 1 and at the beginning of phase 2, there will be elevation of serum bilirubin. And that OTPT trend, that the SGOT and SGPT trend will go down. So this is the time in before the end of first phase and before the beginning of second phase, we should do this HAV and HIV testing. So the chances of having a positive value, we strongly suspect that the patient is having viral hepatitis, is very high. So these are the few basic tests that we can do. And apart from that, if your physical examination tells you that the patient is having features of chronic hepatitis or the patient is having features which is suggestive of chronic liver disease, then at least you should do an ultrasound to see whether the patient is having differential hepatomegaly or a firm liver or a dilated portal vein, or the evidence of any ascites is there or not. Ascites in acute viral hepatitis is also very common. 10% of the patient with this viral hepatitis can have ascitic accumulation, and that is mostly because of this sinusoidal dilatation. Especially in India, we have this very unique thing to our pediatric patient, that most of them are malnourished if they are not on adequate supplementary feed. So in patients who are having malnutrition along with this sinusoidal dilatation, the chances of ascites is very high. So if you are getting a ascites in your ultrasound report, then don't think that it is because of chronic liver disease, but your antenna should be high that it could be a possibility that the patient is harboring chronic liver disease. So that needs to be follow up. But other than that, this is very common, and we consider this as a atypical manifestation of acute viral hepatitis. And another question by sir is hepatitis E vaccine. Yes, it is there. Dr. Reddy's has launched this vaccine in India. And usually, sir, we are not giving it to all the patients, yes, but in special circumstances like pregnant female and those who are having chronic liver disease, where there are chances of hepatitis A and hepatitis E is very high. So we are vaccinating those. But as soon as the efficacy of this vaccine is only 30 to 33%, so routinely, all the gastros are not using this vaccine. But yes, if you find that the patient is high risk or the patient is having chronic liver disease, in pregnant females, those who are living in a very state of harboring this infection, definitely you can use this vaccine. It
Sir,
is
there is a
available in
question.
3-dose regime.
Sir, there is a question and answer section. There is by Dr. Avinash. Role of NAC in acute liver failure and what is the latest recommendation to use it?
For acute viral hepatitis, especially this hepatitis A, E, and B, yes, definitely NAC is very much recommended by all the associations. And during the initial 3 days, we use this medication because after 3 days of acute viral hepatitis, when there is after 3 days of use of this NAC, there is no role, because after initial 72 hours, it can rather hamper the regeneration of liver. So for initial 3 days, definitely we use whether it is acetaminophen related acute liver failure or non-acetaminophen related liver failure. So in both paracetamol induced poisoning and non-paracetamol induced poisoning, NAC is definitely has a role, and it is recommended by all the associations.
There is one more question
Yes, please go ahead.
in the question and answer section. Why are transaminases poor marker of severity in acute hepatitis, whereas INR is a better marker?
So basically, INR is a synthetic function, sir. As albumin, PTINR, all there are synthetic function of liver. Transaminitis definitely has got positive as well as negative predictive mortality value. Sudden drop in transaminases and the patient is not improving has got a negative predictability of mortality. So if your transaminases on one day is very high, 10,000, 15,000 and 16,000, on very next day, your liver enzymes are 500 and 600. That again has got a poor predictive value of mortality. So that should not be the case. It should come down gradually, because if your liver is going into the dead phase, where we call it as a burnt out disease, that means your liver is not able to promote proper functioning, and it has got into the failure. So in that case, your liver enzymes may not be that high because liver is not functioning and there will be no hepatocyte regeneration. So definitely, if the values are very high, that will not tell you that the patient is having only tell you that the patient is having inflammation, but it is not that the patient is having high mortality or it is going towards liver failure. But yes, if they are coming down immediately from a very high range to within hundreds and thousands, then definitely it has got very negative impact over the liver.
Okay. Thank you, sir. Thank you. If anyone has any other question, can put Dr. Ashok.
I think very Dr. Forum, and I have some queries like what are the how we are monitoring these HBV infected children later in adolescence, one thing, and the other question is regarding the treatment. Like you have said, and we have been using UDCA left and right about the role of UDCA in the this hepatitis, and the other thing is this role of this hepatitis B as was what is your experience of using lamivudine, entecavir, lenacapavir, and all those adinofovir? So what medications do you prefer, and which one is more easily available over here?
So your first question was, sir, the role of UDCA. Definitely in patients who are having cholestatic features like intense pruritus, then definitely it has got some role. It is also recommended in patients who are having this cholestatic phase of acute viral hepatitis, mostly related to hepatitis A and E. So almost 20% patients of hepatitis A will eventually have at some point of during their active infection this cholestatic phase. So in that case you can use this UDCA, but otherwise if there is no cholestatic feature, patient is not having pruritus, then there is no role of giving UDCA to your patient. Apart from UDCA, there are other drugs also, cholestyramine we have, rifampicin we have, and in some patients also, if there is no improvement despite giving the UDCA, we can use steroid also for a short duration of 4 weeks. But if there is no cholestatic feature, then there is no point of giving UDCA. And the other question was to use this antivirals and direct acting antivirals for hepatitis C and hepatitis B. So for less than 3 years, we usually have only pegylated interferon, whether it is interferon or pegylated interferon. In less than 3 years, we can use for 6 to 12 weeks. And they are very effective, almost 50% efficacious in combating the infection. But above 3 years, in hepatitis B, we have entecavir, which is a very good drug and easily tolerable drug by the children. We can give this medication. And for hepatitis C, we have direct acting antiviral, whether it is ledipasvir along with sofosbuvir or sofosbuvir with velpatasvir. Both are very good tolerability, and above 3 years we can use this medication for genotype 1 and 4, and this velpatasvir and sofosbuvir for patients who are having all genotype hepatitis C. So these are the medication which is available if the patient has got this DNA positive for both C and B and detected early in those whose mother during transmission has E antigen of more than 2 lakh, or mother was taking treatment and you found to that the patient is positive for both the DNAs, then you can start treatment as early as 1.5 years of age with interferon for hepatitis B, and you have to wait till 3 years for starting treatment for hepatitis C in form of direct acting antivirals.
Okay. I wanted to ask one more thing. Monitoring of these hepatitis B infected children.
Yes. So the first time you ask for a test is that hepatitis surface antigen titers, which we usually do after 1 to 2 months of the last dose of primary series of hepatitis B vaccine. So if that time patient is positive, we again do this investigation after 6 months. And if after 6 months also patient is positive and DNA is positive, then sequentially every 6 months we do this LFT and replicative markers. And if LFT is on the rising trend, especially this ALT is on the rising trend and more than 2 times of the upper limit, then we should start the patient on therapy. And in immediate scenarios, if the patient is showing a rising trend of ALT and mother to child transmission is very suspicious and patient's mother is also positive, then at any point of time you can start this interferon.
Okay.
So ALT is very important. If the patient is having normal ALT, 6 monthly you can screen the patient, and if ALT is increasing, then first at 1 to 2 months of the last dose of vaccine, then at 6 months, and if 6 months is also positive, then you can start the therapy.
When do you do the core antigen?
Sorry, sir.
When do you do the core antigen? HPC?
HPC. Sir, I cannot hear you. Can you please repeat the question?
HPC antibody in chronic hepatitis B children, like HBE antigen.
HBE antigen, sir. These are
endemic
also a
disease.
this is also a
Replication.
replicative marker, sir. Anti-HBE, HBE antigen, anti-HBC IgM, anti-HBC IgM total HBV DNA. These are all replicative markers for hepatitis B. Ideally, we should do these investigation at the time of initial workup only. And if patient is having HBE antigen positive, anti-HBE is negative, hepatitis B DNA is more than 20,000, and anti-HBC IgM positive, and total is plus minus. So you can start the therapy. So that means patient is in immune active phase. And in case of reactivation also, we have to start this thing. But in reactivation, usually patient will have a normal ALT values, normal DNA titer during the initial phase. But yes, in future or later life, again, there will be elevation of enzymes and DNA. So that means the patient has got reactivation. So this is a special circumstance and you have to start the therapy.
Thank you. Thank you, Dr. Ashok. Any other query?
There is one more question in question and answer section. When to use HEPA-MERS? Is it recommended to all the patients?
For ALF patient, we do use this HAPA-MERS, but there is no recommendation as such for this branch chain amino acid and this L-arginine L-aspartate therapy for any of the condition.
People are using for just plain hepatitis. That's why I think this question is there. One silymarin is also there for that reason.
Yes, sir.
Okay. Anything else? I think today I think we have discussed mainly the hepatitis B and C. Hepatitis A and hepatitis E was just like sidelined discussion. So I think we will have some more discussion on those topics also. And thank you very much, the speakers. Over to Dr. Amit.
Thank you, sir. And thank you, Dr. Ashok Goel. You took a time for today's session and agreed to moderate the session. It was a wonderful session. We are aligned with your experience and knowledge. Thank you. I would also like to thank IAPS Delhi for starting this informative CME series on standard treatment guidelines. And last but not the least, I would like to thank all attendees who took out time to join the session today. Thank you.
Thank you very much.
We can.
Sushil to, yes. Please continue.
Yes. दानी मैंने करके निकाल देगा अच्छे से इसको तो अच्छे से लगा अभी निकाल देगा घंटा आप दूसरा ढूंढ रहे होगी